What if I told you that putting a metal stent into a blocked, struggling heart artery, like the ultimate medical plumbing fix, right? What if I told you that doesn't actually stop you from having a heart attack?
I mean, it's a massive paradigm shift.
Yeah.
And it honestly goes against almost every intuition we have about how the human body works. But when you look at the data, it completely rewrites the rules.
It really does.
Today, we're looking at a really dense, high-yield clinical breakdown of stable angina pectoris, and we're pulling directly from the absolute latest, most authoritative guidelines available.
Right, the AHA and ACC from 2023.
Exactly, and the ESC from 2024. This is the exact evidence-based management strategy used by cardiologists worldwide right now.
Okay, let's unpack this, because whether you are a medical student who's cramming for your board exams, or maybe a curious learner trying to navigate a family member's recent diagnosis, or just someone listening who wants to understand the sheer mechanics of the human heart.
Which is fascinating on its own.
Right. We're going to translate this absolute mountain of medical guidelines into crystal clear insights. So our mission for this deep dive is to figure out how modern medicine tackles predictable chest pain.
Yes.
We really want to separate the treatments that just, make a patient feel better today from the ones that actually keep them alive tomorrow.
And that distinction between feeling better and staying alive, that is really the core tension of these entire guidelines.
Yeah.
But I mean, before we can treat the problem, we have to establish exactly what is happening inside the chest.
Right. Let's establish the baseline here. So we were talking about stable angina.
Right.
And by definition, this is predictable chest pain, or like tightness or discomfort. It happens when you exert yourself physically, like climbing a steep flight of stairs.
Or running for the bus, yeah.
Exactly. Or maybe when you're under intense emotional stress. And crucially, it goes away when you rest or take a specific medication, like nitroglycerin. So think of the heart like a car engine, right? And it's trying to accelerate up this really steep hill, but the fuel pump just cannot deliver enough gas.
That's a great way to picture it.
The engine doesn't blow up, but it knocks, it sputters, and it sends a warning signal that it just can't keep up.
What's fascinating here is the precise pathophysiology of that sputtering engine. I mean, it all comes down to a fundamental mismatch.
A mismatch between supply and demand.
Exactly. The myocardial oxygen supply, meaning the actual blood delivering oxygen to the heart muscle, is failing to meet the myocardial oxygen demand.
Because the heart is working harder.
Right. It demands more oxygen, but you have a narrowed coronary artery that's restricting that flow. However, there is a crucial diagnostic silver lining here, which is what separates stable angina from an actual heart attack.
It is?
It is entirely reversible.
Okay, wait. Reversible meaning that the tissue itself isn't dying.
Exactly. The medical term is that there is no myocardial necrosis.
Wow.
No tissue death. Yeah. So if a patient comes into the ER and you run a blood test for troponin.
Which is the specific protein that spills into the bloodstream when heart muscle cells burst and die, right?
Right, exactly. That test will come back negative. So the heart cells are angry. They are starved for oxygen, and they're basically screaming in pain, but they are very much alive.
Which gives the medical team a window to act.
Yes, a vital window.
And the guidelines lay out this massive, multi-step strategy to fix this. They use the 4 R's, right?
Yep, the 4 R's. Relieve symptoms, reduce ischemia, reduce future events, and restore functional capacity.
Right. But if we go back to our car engine analogy, if the engine is struggling because of restricted fuel lines, how do we stop the entire system from deteriorating permanently?
That's the million-dollar question.
Because I'm looking at the initial steps in this source, and it's heavily focused on lifestyle modifications, but it presents them as like hard medical interventions, not just casual suggestions like, eat your vegetables.
Right, because they aren't casual suggestions. Historically, we thought of clogged arteries like pipes gathering rust over time.
Just a passive buildup.
Right, but atherosclerosis is not rust. It is a highly active inflammatory biological fire.
Oh, wow.
Yeah, the inner lining of your blood vessels, the endothelium, it's only 1 cell thick.
1 cell. That's incredibly fragile.
It is. And when you smoke cigarettes, for example, the chemicals literally shred that delicate endothelial lining. They accelerate that inflammatory fire. So complete smoking cessation isn't just a good idea for overall health. It physically halts the active destruction of that lining.
That makes total sense. And the diet piece. The guidelines specifically mandate a Mediterranean-style diet.
Right, because foods that are rich in omega-3 fatty acids, like fish and nuts, along with olive oil, they actively reduce oxidative stress at the cellular level.
So they're not just like empty calories.
No, they act like a biological coolant for that inflammatory fire inside of blood vessels.
Okay, but cooling the fire with diet and smoking cessation usually isn't enough when a patient already has established symptomatic heart disease, right?
Yeah, usually not, no.
Which leads us to the heavy hitters of disease modification. Statins and antiplatelets. Let's start with statins. The source material talks about aggressively targeting LDL, which is, the bad cholesterol.
Highly aggressive. For a patient with stable angina, high-intensity statin therapy, using drugs like atorvastatin at, say, 40 to 80 milligrams, is mandatory unless there's a strict contraindication.
Wow.
Yeah, the European guidelines actually want that LDL cholesterol pushed below 55 milligrams per deciliter.
Below 55, that is incredibly low. Why such an extreme target?
Well, it's because of what statins actually do. Yes, they lower the bad cholesterol circulating in your blood, but their superpower is that they stabilize the plaques that are already built up inside the artery walls.
How does that work?
Think of a cholesterol plaque like a pimple inside the artery.
Oh, gross, but okay.
Right, but if it pops, a blood clot forms instantly and you have a massive heart attack.
Oh, wow.
So statins pull the inflammatory lipids out of that plaque and they thicken the fibrous cap over it. They literally turn a dangerous, volatile, angry plaque into a hardened, stable scar that is far less likely to rupture.
Okay, so the statin stabilizes the wall of the artery, but we also need to address the blood flowing through it, which is where aspirin comes in.
Exactly. Step 3 in the algorithm.
The guidelines recommend 75 to 100 milligrams daily. And aspirin stops platelets from clumping together, right?
Yeah.
Making the blood less sticky so it can glide past those narrow plaques.
That's exactly right.
But I have to ask, I mean, logically, if one blood thinner like aspirin is good at keeping the blood flowing, why stop there? Wouldn't dual antiplatelet therapy, like using aspirin alongside another blood thinner like clopidogrel, wouldn't that be twice as effective at preventing a clot?
It is a totally logical leap, but the guidelines are fiercely clear on this. Dual antiplatelet therapy, or DAPT, is not routinely recommended for uncomplicated chronic stable angina.
Wait, really? Even if the ultimate goal is preventing a clot, I feel like you'd want maximum protection.
Well, in medicine, everything is a precise trade-off. Treating stable, predictable angina too aggressively with multiple blood thinners introduces massive bleeding risks.
Oh, I see.
Yeah. If a patient hasn't had a recent acute event like a heart attack, or they haven't just had a stent placed in their heart, the statistical risk of them having a severe, life-threatening bleed, like a hemorrhage in the brain or a massive GI bleed, that actually outweighs the benefit of that second blood thinner.
So the cure becomes worse than the disease.
Exactly. Aspirin alone hits the perfect equilibrium for stable disease.
That makes perfect sense. The goal is to thin the blood, not turn it to water.
Right.
Now, before we move to how we stop the actual chest pain, the guidelines highlight a major shift in how we handle patients who have stable angina and type 2 diabetes.
Yes.
The text mentions SGLT2 inhibitors and GLP-1 receptor agonists.
I mean, this is arguably one of the most profound developments in modern cardiology. Oh, absolutely. For decades, if a heart patient had diabetes, we basically just gave them drugs to lower their blood sugar. But these new drug classes, SGLT2 inhibitors like empagliflozin and GLP-1 agonists like semaglutide, they are doing something far more complex than just sugar management.
How so? Like, what are they doing to the heart itself?
Let's take SGLT2 inhibitors.
Right.
Yes, they make the kidneys excrete excess glucose into the urine, but mechanically, they also act as a gentle diuretic.
Meaning they remove excess fluid.
Right, which reduces the fluid volume and the physical pressure the heart has to pump against. But even more fascinating, they force the heart to shift its metabolism.
What do you mean by that?
Instead of burning glucose for energy, the heart starts burning ketones, which is a much more efficient oxygen-sparing fuel source.
Oh, wow. So it changes the engine's fuel type entirely.
Exactly. And as a result, these drugs actively reduce heart failure hospitalizations and prevent major adverse cardiovascular events. They are fundamentally protecting the heart's machinery.
Okay, so we've established the foundation. We've cooled the inflammation with lifestyle. We've stabilized the plaques with high-intensity statins. We've got aspirin making the blood slippery, and we're optimizing the metabolism. So the patient's long-term survival is looking great.
Okay, very good.
But they are still getting crushing chest pain every time they try to walk to their mailbox.
Right, the everyday reality.
Yeah, they need to get through their day. So how do we physically stop the pain right now?
Now we transition from disease modifiers to symptom relievers. And the first-line pharmacotherapy for this relies on some of the mechanics. We either have to reduce the heart's demand for oxygen or increase the blood supply.
And the undisputed champions of the first-line approach are beta blockers, right? Drugs like metoprolol, bisoprolol, or carvedilol.
That's right.
If a patient swallows a beta blocker, what is physically happening inside their chest, say, 30 minutes later?
Beta blockers are essentially putting a strict speed limit on the heart. They block the sympathetic nervous system, the adrenaline receptors, from whipping the heart to beat faster and squeeze harder.
Okay.
So by lowering the heart rate and reducing the contractility, which is the force of the squeeze, you drastically reduce the heart muscle's oxygen consumption. It simply doesn't need as much fuel, so it stops sending pain signals when the patient climbs those stairs.
So it lowers the demand. But does it do anything for the supply side of the equation?
It does, actually, through a pretty brilliant piece of physiology. The heart is unique because it receives its own blood supply during diastole.
Which is the resting phase between beats.
Exactly. When a beta blocker slows the heart rate down, it stretches out that resting phase. It gives the coronary arteries a much longer window of time to fill up and deliver blood to the heart muscle itself.
Oh, wow. Lower the demand, increase the filling time. It's like a perfect mechanical fix.
It really is.
But they aren't for everyone. The text lists some strict contraindications like severe active asthma. I assume that's because those same beta receptors exist in the lungs, and blocking them might trigger an asthma attack.
Correct. And obviously, if a patient already has symptomatic bradycardia, meaning their baseline heart rate is already dangerously slow, you cannot put a speed limit on a car that's barely moving.
Right.
If beta blockers are contraindicated, or if the patient just can't tolerate them, the guidelines pivot to calcium channel blockers, or CCBs.
Drugs like amlodipine or verapamil, but the source has this massive flashing red warning about how you use these.
Yes, because there are two very distinct types of calcium channel blockers. You have the dihydropyridines, like amlodipine.
Okay.
These act mainly on the peripheral blood vessels, forcing them to dilate and open up. This lowers blood pressure and makes it easier for the heart to pump. But then you have the non-dihydropyridines, like verapamil and diltiazem.
And those are different.
Very. These act directly on the heart muscle itself, slowing the heart rate down, very much like a beta blocker does.
Which leads to the danger warning.
Absolutely. You must explicitly avoid routinely combining those non-dihydropyridines, the verapamil or diltiazem, with a beta blocker.
Because they both apply the brakes to the heart rate.
Exactly. If you stack them, you risk causing a high-grade AV block.
What's that?
The AV node is the electrical relay station of the heart. If you suppress it too much with both drugs, the electrical signal from the top of the heart gets completely blocked before it reaches the bottom.
Oh, wow.
The heart essentially forgets to beat. It's a profound, life-threatening rhythm issue.
Okay, duly noted. Do not mix the two heavy breaks. But what if a patient is safely taking a beta blocker, they're on the max dose, and they still have angina? The guidelines offer several add-on therapies, right?
Yes, the second-line options.
Like ranolazine, which alters cellular sodium and calcium without dropping blood pressure, or ivabradine.
Ivabradine is quite elegant. It slows the heart rate by specifically targeting the SA node, which is the heart's natural built-in pacemaker.
Oh, nice.
But it only works if the patient's electrical system is firing normally, what we call normal sinus rhythm.
Got it. And then, of course, there is the medication everyone knows from like movies and television.
The famous one.
Right. The ultimate acute relief medication, short-acting sublingual nitroglycerin, the little tablet you dissolve under your tongue.
Yeah. If a patient feels the predictable chest pain starting, or they know they're about to do a strenuous activity like shoveling snow, they use it.
And what does it do exactly?
Nitroglycerin rapidly converts to nitric oxide in the body, which violently dilates the blood vessels. That takes a massive amount of workload off the heart almost instantly.
But reading the patient education rules for nitroglycerin, I mean, it reads like a tactical protocol.
It really does.
Yeah, the first rule is that the patient must physically sit down before taking it. Why is that?
Because that rapid vasodilation causes a sudden steep drop in blood pressure. If they're standing up, gravity will suddenly pull the blood down to their legs, their brain will lose perfusion, and they will pass out.
Oh, wow.
Yeah, and potentially suffer a severe head injury from the fall. They have to sit down.
Makes sense.
Yeah.
The second rule is about dosage. So take one dose. If the pain is still there after 5 minutes, you do not just take another one and wait patiently. You immediately call 911.
Immediately.
Because at that point, you might not be experiencing stable angina anymore. A plaque might have ruptured, and you could be having a heart attack.
Exactly.
And while waiting for EMS, the guidelines say you can take up to a maximum of 3 doses spaced 5 minutes apart.
It is a critical safety net. We have to reiterate our core mission here. Nitroglycerin brilliantly relieves symptoms and buys time, but it has zero proven survival benefit.
Right. It does not stop a heart attack from happening.
No, it doesn't.
Here's where it gets really interesting, though. There is an absolute non-negotiable contraindication for taking nitroglycerin. It involves a severe drug interaction.
Yes. A patient must never, under any circumstances, combine nitroglycerin with a PDE5 inhibitor.
Which are medications typically used for erectile dysfunction, like sildenafil or tadalafil?
Correct. If a patient has taken sildenafil within the last 24 hours, or tadalafil within the last 48 hours, and they take nitroglycerin for chest pain, the synergistic effect on their blood vessels is catastrophic.
Catastrophic in what way?
The vessels dilate so wide that it causes profound, life-threatening hypotension. Their blood pressure bottoms out completely, and there's just no blood flowing to the brain or the heart. It is a fatal combination.
That is terrifying. Okay, so let's zoom out a bit. We've optimized their lifestyle. We have them on statins and aspirin to protect the arteries.
Yep.
We've given them beta blockers and nitroglycerin to manage the pain. But let's say the pain is still there. It's limiting their life. They can't play with their kids. Naturally, you'd think, okay, the pills aren't enough. It's time for surgery.
It's the logical next thought.
Right. Let's talk about PCI percutaneous coronary intervention. That's when a cardiologist threads a catheter up into the heart and deploys a metal stent to pry the blocked artery open.
Right?
Opening the pipe must automatically save their life and stop them from having a heart attack.
If we connect this to the bigger picture, this is where human intuition totally betrays us.
Wait, really?
Routine coronary revascularization. Putting a stent in via PCI in a patient with stable ischemic heart disease, assuming they don't have extremely high-risk complex anatomy. It does not reduce death.
What?
And it does not reduce the risk of a future myocardial infarction compared to optimal medical therapy alone.
I just want to make sure I'm understanding this. If I have stable angina, meaning I have a predictable chest pain from a 70% narrowed artery, putting a metal scaffold into that exact artery to pry it open doesn't make me live longer.
That is exactly what the clinical trials show.
That's wild. Why?
To understand why, you have to understand heart attacks actually happen. A heart attack rarely happens because a 70% blockage slowly grows to 80%, then 90%, and slowly closes off.
How does it happen then?
A heart attack usually happens when a minor non-obstructive plaque, maybe only a 30% or 40% blockage that never even caused chest pain, suddenly becomes inflamed, ruptures, and forms an instant blood clot that stops flow 100%.
Oh, so the little ones are the dangerous ones.
Exactly. If you put a stent in the 70% blockage, you fix that one specific spot, but you did absolutely nothing for the dozens of 30% blockages scattered throughout the rest of the heart.
Wow.
The stent treats a focal point. Atherosclerosis is a systemic disease. The statins, the aspirin, the blood pressure control, those treat the entire system.
Okay, so what is the stent actually doing for the patient in this scenario?
It is the ultimate symptom reliever. If you cannot walk up a hill without crushing chest pain despite taking maximum doses of beta block,
you would likely need stenting then. Although beta blockers, calcium channel blockers will help with hypertension, but you may need ACE inhibitor, RARBs, and specific indications like heart failure, myocardial infarction, diabetes mellitus, and chronic kidney disease. The patient may need to be shunted to the ACS pathway if there is angina at rest, crescendo angina, chest pain lasting more than 20 minutes, new heart failure signs, for example, raise S3, JVP elevation and edema, syncope or presyncope, hypotension or cardiogenic hypoperfusion. These patients require immediate reassessment. Beta blockers will reduce mortality only if they are in a MI or heart failure setting. High intensity statins are very good for risk reduction. ACE inhibitors or ARBs are best for hypertension, diabetes, CKD, and EF below 40%. Routine PCI without high risk anatomy does not reduce death as compared to GDMT. It only improves quality of life. So for angina, treated in A, B, C, D, E, and R plus algorithm. Thank you very much for staying with us. Stay tuned for more updates and more material according to learning objectives by KMU.